So again, switching concepts here. We've been plowing through cellular regulation at multiple levels with our cancers. We introduced you back into infection when we talked about tuberculosis. And now we're going to kind of dip back into immune system disorders or immunity with the topic of HIV and AIDS. So again, reviewing this concept of immunity, the body's natural or induced protective responses, and of course those things that make up the network that allows our body to protect itself, including those B cells and T cells, and that's very relevant here with AIDS. So we'll talk about those T cells in particular, and of course our body's ability to protect itself. Got some fantastic statistics here that I just want you to take the time to look at. Very interesting as far as the regions that are affected by AIDS, and what a significant difference when you look at how the effect here in the South at 49%. How those statistics play out: 67% among gay, bisexual, and other men who reported male-to-male contact, 67%. 22% among people who reported heterosexual contact. And then, we make a big deal about drug injection, but only 7% of those total population. So not quite what you think, okay? Disparities, our Hispanic and Latino are our high ethnicity population here, and then Black and African American. HIV diagnosis among heterosexuals. This is where Black and African American takes the lead, and then Hispanic, and then white. So the populations that are being affected is different between gay and straight populations. White people accounted for the highest number of new HIV diagnoses among people who inject drugs. So when we talk about that 7%, interesting that white people account for the highest number of those people who are affected by this. Age, the highest number of new infections occurs in people 25 to 34 years old, and ages 13 to 24% comprise 20% of that new case population. So staggering. So what is HIV and AIDS? AIDS is a virus. HIV, human immunodeficiency virus, and it weakens the immune system, and specifically CD4 cells, and we'll get into what those CD4 cells are in a little bit. There currently is no cure for this. We start off with the human immunodeficiency virus, and it can progress to AIDS, and it can spread through all the body, blood and fluids. So again, going back to our diagram here, we have those neutrophils, eosinophils, and basophils, those things that you see in your CBC with differential, right? Those different types of white blood cells, and they have different functions. We talked about that early in our 151s. And just to review, like eosinophils, you see those with parasitic infections, you see those with allergic reactions, those will be elevated. The basophils, okay, these neutrophils, these are our predominant ones. They're the ones that are busy out there protecting the body, that first response. And then we come over here to these agranulocytes, those lymphocytes and monocytes, and specifically these lymphocytes, they break down into those B lymphocytes, T lymphocytes, and neutrophils. And you can remember those from your immune lessons where we're talking about these secondary response, right? After those white blood cells go in and they attack something and they tag it, and then the body produces a secondary response that is faster the next time we're exposed to something. And so this is where we're going to see the trouble right down here with these T lymphocytes. So AIDS is that acquired immunodeficiency syndrome. That's what the acronym stands for. And what we need to know about AIDS is that it is the final stage of an HIV infection. And so we ask ourselves, how do we know when HIV has progressed to AIDS? Well, what we see are some things that we don't see in the HIV process. We see more opportunistic infections, and we'll talk about what those are in a little bit. We see certain cancers that are very high in a HIV/AIDS population. And then we see this low number of CD4 cells. And again, we'll get into what those CD4 cells are a little bit later. Those people at higher risk for HIV/AIDS are people who have unprotected sex of any kind. Again, being in a marriage is not a guarantee that a partner is unfaithful, and unprotected sex of any kind puts you at risk for HIV/AIDS. People who have multiple partners, that kind of speaks to itself. Occupation as a healthcare worker. And I know we talked about my experience with my first fluid-to-fluid being sprayed in the eye with urine from a catheter, and the concern and having to have AIDS testing for 6 months after that. IV drug use with contaminated needles. So again, not a big population, right? That's 7%, but this is how it's happening, right? So if you have IV drug use, people who are using needles multiple times or sharing needles, it can occur perinatally, transmission from mother to baby. And of course, I had experience with this when I went to Africa, and we can talk about that maybe a little bit more in class. And then contaminated blood products, although this one we really clamped down on, right? This is something that happened in the early days of HIV/AIDS when we didn't understand it, and people were being given the virus through blood transfusion. Here we have a picture of kind of the progression of HIV/AIDS. So we talked about those CD4 cells right here. They're a type of T lymphocyte. And before infection, you see a normal amount of these in the blood doing their job, protecting the body. Patients get an acute infection with HIV, and so you see all of these HIV molecules in here. And then that's that acute phase. It moves out of that acute phase and into that chronic infection, and things kind of even out a little bit more here. So you see there's been that destruction of the CD4 cells, but there's not quite as much of the HIV virus in the blood. And then as that progresses over the years, you can see that eventually the CD4 cells, which are affected by the HIV virus, they decline, and the virus takes over. When we're looking at the stages of progression in terms of symptoms, we have that initial phase. So if you think back to that acute infection, so when they were first exposed, patients may experience flu-like symptoms and they may start anywhere 2 to 4 weeks after the infection. Okay, very indistinguishable from any other type of flu, right? They're going to have flu-like symptoms, but there's going to be that rapid rise in the viral load. So if you go back and you refer back to that previous slide, you can see those CD4 cells are there, right? But the virus load is very heavy, okay? There's a decrease in the CD4 counts. It's during this time, and the patient is very contagious. So again, you can see if they're thinking they have flu-like symptoms, they've been exposed, and this is 2 to 4 weeks after the infection, high levels of the HIV virus in their blood and body fluids, and they think they've got the flu. They continue with risky behavior, and you can see how that can spread, okay? So then we move into stage 2 of the progression. They may still be largely asymptomatic, basically asymptomatic. So think too, when you move into that chronic phase where the CD4 cells are slightly diminished, but not enough to affect the body in a significant, noticeable way. And the HIV virus is still there, it's reproducing, but it's just kind of slowly generating. And this phase can last 10 years or longer, okay? You can still transmit the disease. It's not that they're not infectious, right? Just because they're very infectious in the first stage doesn't mean that during this phase they're not infectious. They are, okay? But with meds, they may never move to the AIDS, okay? We think of Magic Johnson. He's kind of the poster child for this HIV/AIDS, but you know, someone who's lived a long time with the virus and proper medication. So with medication compliance, they may never move to AIDS, but they still have a high viral load. It is affecting those CD4 cells, so those numbers are lower. The body has less ability to fight off the infection. And so this is where we begin to see these opportunistic infections. So when we talked about those symptoms for each stage, let's get a little bit more specific as to what we might see. So in that stage 1, where we have those flu-like symptoms, we might see fever, headache, rash, fatigue, chills and muscle pain. You may have some oral ulcers or sore throat, but again, nothing that's going to really, distinguish this from your average flu type symptoms. Stage 2, in that chronic phase, they may start to develop coughing and or breathing difficulties. There may be some weight loss. The diarrhea may occur in this phase, especially if they're not being treated. Fatigue, and then higher fevers. Okay, and then when we get to that stage 3, where we have the AIDS, the full-blown AIDS, they're going to have persistent high fevers. They're going to be so susceptible to those infectious processes. So whether it's urinary tract infections, respiratory infections, cellulitis, all of these things, very, very susceptible to that infection. We're moving from chills, which we might have with our acute, to severe chills, rigors, cachexia, they're not able to maintain that body heat, and then night sweats. And again, here we see night sweats. We see it with TB, we see it with lungs. So when we talk about the fact that we don't make diagnosis based on really one thing, this is exactly what we're talking about. We've got 3 serious diseases here for which those night sweats are a significant factor, right? So we have to have lots of information, and we have to rule things in and rule things out. We may have oral white spots, again, opportunistic infection, candidiasis, so in the mouth, those the yeast infection in the mouth. They may have genital or anal sores, again, infectious skin breakdown. They may have rashes that are brown, red, pink, or purple. And we'll talk about these a little bit more. Even more seriously for those rashes is the potential for cancer. They're going to have that severe weight loss and cachexia, right? Between the increased diarrhea, so at this stage 3, the diarrhea is just very, very hard to control. I should have diarrhea here at stage 3. But that's part of that severe weight loss and cachexia. And of course, when you're having diarrhea, you just don't feel good. You don't feel like eating. They may encounter memory problems, or what we call AIDS dementia, and we'll talk about that a little bit. And then most severely, this pneumonia, which is a significant mortality factor, a specific type of pneumonia that's associated with AIDS. As far as diagnosis goes and kind of measuring the health of the immune system, we're looking at the CD4 count. We talked about that before. You saw it in those diagrams. This CD4 is a crucial lab that we're looking at. And of course, this tells us how many healthy CD4 T cells we have. And a normal is greater than 500, so 5 to 1500. And then you can see here the CD4 count less than 200. When we get to that point, that's a diagnosis of AIDS. We've moved from HIV. We do not have the CD4 cells in the body to combat disease, and we move into that opportunistic infection type period. We're also looking at the viral load. So we're actually looking at the amount of HIV virus in the blood, okay? And then we can do a rapid HIV test, which is another diagnostic tool. What we're really looking at initially are these 2 tests here, this ELISA test, which is the enzyme-linked immunosorbent assay. And of course, this is a common screening test for HIV and antibodies. If it is positive, so this is a cheap test, it's an easy test, okay? If this is positive, then we need more confirmation. Then we move on to the Western blot. So we don't do both of these at the same time. Normally we start with the ELISA, and then if that is positive, we move on to the Western blot. We use the ELISA because it's inexpensive, it's accurate, we have very few false positives, so if it's positive, we can be fairly certain that this is HIV. After we get that positive, we do a Western blot test. This again is also an HIV antibody test, so it confirms HIV, it corroborates it with the ELISA, and with the ELISA result, the combination of those two, if these are both positive, it's a 99.9% reliability that this person has HIV. Okay, that's a little bit more expensive, So we do it for that confirmation. If the ELISE is negative, there's very little reason for us to proceed to a Western blot test. A little bit newer is this NAT test. It looks for the actual virus in the blood. It can tell if a person has HIV or how much virus is present in the blood. So it's also looking at that viral load that we talked about. How much HIV virus is there in that blood per unit of blood? It can detect HIV sooner than other types of tests. So usually there's kind of that post-exposure period where that HIV may not be detectable. This test can actually detect it sooner in the blood. And so this is indicated for people who've had a recent exposure that they know about, or possible exposure. If they have early symptoms of HIV and they've tested negative with antibodies or antigen antibody tests, these are our people who are going to be looking at this NAT test. Now, I know that we talked about this kind of principle a little bit when we talked about colorectal cancer. So for people who this is more delicate, or maybe they're more difficult to reach or to get into, be tested or treated, we can order an HIV self-test. Okay, so there's this link here, gettested.cdc.gov. You can see if anybody in the area is offering free or reduced cost self-kits. You can also buy an HIV self-test kit at a pharmacy or online. So this can be used at home or in a private location. That would be very scary, obviously, but with an HIV self-test, you can get your test results within 20 minutes. And of course, if there's anything positive about that, you're going to want to follow up with that with official testing. So we talked about it a little bit when we talked about the progression of HIV or AIDS. How do we know whether we have HIV or AIDS? Well, if it's HIV, we're going to be positive for the HIV virus. Okay, so we're going to have a viral load that reflects HIV in the blood. These CD4 cells, they're going to be greater than 200 millimeters cubed, and that's about 14 to 28%. So that is HIV, right? If we're above that 200 mark in the CD4 cells, we are in the HIV range. As far as AIDS, we're going to be positive for the HIV virus, so that's similar. You can see when we look at the CD4 cells, though, as we look back on that nice diagram that we had at the very beginning, our CD4 cells have dropped significantly, right? Now they're below that 200 mark. So our immune protection is being destroyed. Okay, those CD4 cells are our immune protection, and they're being destroyed by the HIV virus. And then, of course, the onset of those opportunistic infections, and that's really key too, because that is pointing us to the fact that the immune system cannot fight off what are normally things that the body fights off, right? When we call them opportunistic, we mean that they're taking advantage of the current state of immunosuppression in the body to take over and to thrive and multiply. When we talk about management, obviously we have to start with prevention. Most importantly, right? So safe sex practices is one of those, protecting ourselves regardless of our sexual practices. IV drug use, which again is a small population, but needle exchange, so exchanging used needles for clean ones. Using standard precautions when we're treating patients, making sure that we're gowned and gloved and that we're careful with bodily fluids. Even more so when we know whether or not a person has HIV or AIDS. We're going to treat all clients alike. That should go without saying, right? We take care of patients regardless of what their concerns are. But we do treat all high-risk body fluids as infectious. So whenever we're dealing with body fluids, we are gloving up, potentially gowning up. If it's a risk for spray or jettisoned body fluids, we're going to make sure that we have eye protection. So we're taking care of ourselves. As far as CDC screening for HIV, the recommendation is for one-time screening for adults 18 to 65 years, or if they're pregnant. There are things that we want to do for our babies if this is a concern. Annual testing for high-risk adults, so IV drug users, sex workers, anyone who had a transfusion before 1985, and I can tell you I was around then. We'll probably talk about that a little bit more in class, but someone who had a transfusion before 1985 is someone who would want to have screening. And then someone who had a sexual partner who was infected. These are our annual testers. Let's dig in. So when we talk about treatment, no drug can cure HIV, first of all. It's important to reiterate that there's currently no cure. We use 5 different classes of HIV drugs, and each attacks the virus at different points in its life cycle. Where have we heard this before? TB, 4 different drugs for 2 months attacking the virus in various ways, or bacteria in various ways. Our cancers, using multiple classes of drugs to attack these fast-growing cells in various stages of their cycles and at various points of vulnerability, right? Like with the angiogenesis medications. Taking a single drug by itself won't stop HIV. So best course is be taking 3 to 4 different meds. That does the best job of controlling that amount of virus in the body and protecting the immune system. Understanding that the goal is to keep that viral load low and to keep our CD4 count high. We have 2 goals there, right? We want to keep that load low. We want it to not damage our CD4 cells. We need those CD4 cells for our immune system health. So we're talking about therapy. It's called CART therapy, combination antiretroviral therapy. Downside is expensive. Downside is it needs to be taken at a specific time. Downside is that it compounds some of the already present concerns with HIV/AIDS, the anemia, the neutropenia, diarrhea, which is a difficult to control issue in this particular disease, and then something called lipodystrophy, which is just an abnormal subcutaneous fat distribution. The goal for the patient is to take 90% of their doses on time. Again, considering the populations, that can be a pretty difficult goal, as well as the difficulty of the regimen with multiple drugs, specific times, and so forth. So a lot harder than it sounds as far as a goal of treatment. And then, of course, the concern is that drug resistance will develop as doses are missed. Like other medications, there is the concern that the patient will develop a resistance to their drugs. Another use of our CART therapy is post-exposure prophylaxis. This is this AZT therapy. It's antiretroviral medication. And this is when someone has been exposed, and we're going to do it prophylactically. So they start treatment with 2 to 72 hours, and they treat for 28 days. Let's talk about complications of AIDS. I alluded to this a little bit in the earlier on in the presentation. That there, as far as symptoms and stages, this AIDS dementia complex, which is a complication of HIV progression to AIDS. It's the most common cause of mental status change for patients with HIV. It directly affects the brain, so there's fluctuations that involve memory loss, confusion, concentration, lethargy, loss of motor speed, and even apathy. And of course, we have concerns for non-Hodgkin's lymphoma and toxoplasmosis with this AIDS dementia complex. When we talk about opportunistic infections, we're talking about those infections that take advantage of a compromised immune system and are able to proliferate. And one of the most common of these among the AIDS is this pneumococcus jirovecii. I think that's how it's pronounced. I forget now. It's a rare pneumonia associated with AIDS. And again, it's the most common opportunistic infection and a common cause of death. Okay, so again, these patients are dying from complications of AIDS. So all the things that the HIV virus is doing to the body, patients are dying because of complications of that virus. Fungal diseases, so we talk about those white spots in the mouth as a symptom. Those fungal diseases can include the candidiasis in the mouth. That's an opportunistic infection. Urinary tract infections, which I haven't listed here, but is a common opportunistic infection. And then tying it back into our previous slides with this TB, right? We talked about it when we talked about TB, that was a risk factor. Well, here we're kind of reflecting back now. This is an opportunistic infection for which HIV and AIDS patients are very susceptible. Okay. All right, so there are two cancers that are associated with HIV/AIDS, and that is Burkitt's lymphoma, okay, which is a lymphoma. It's a lymph system cancer, and then Kaposi sarcoma, which is actually a skin disorder associated with AIDS. And sadly, once you see this, the survival time is about 18 months. So this is kind of a prognostic indicator, right? This tells us that when we start to see this Kaposi sarcoma, this patient is heading towards the end, okay? But it is a specific form of skin cancer, and it's highly associated with HIV/AIDS. Going into it a little bit further, this is what we're looking at. You can see the pictures on the side here. Types of cancer, painless purplish spots on the legs, the feet, or the face. These can also be in the genital area, the mouth, or on the lymph nodes, so they can be inside. Severe lesions can develop in the digestive tract and the lungs. And people with HIV are those most at risk for developing this specific type of cancer. So let's take a look at our nursing role for HIV/AIDS. Our role is to help prevent infection, to encourage adequate nutrition. Again, these people are anorexic, cachexic, highly malnourished, mouth sores, diarrhea, all kinds of things going on there. We're going to manage diarrhea. Again, that's a real problem with HIV/AIDS. So we're going to have to help patients try to manage that and reduce some of the concurrent issues that happen with chronic diarrhea. We're going to maintain skin integrity, as it should be obvious. There are a lot of things that go on with the skin, the Kaposi sarcoma, the oral ulcers, rash from diarrhea, skin breakdown from malnutrition. So we are definitely going to be managing skin integrity. And then, of course, gas exchange. We're having concerns about opportunistic infections and the impact that those have, the most common being the pneumonia and the most common cause of fatality in HIV/AIDS patients. So we're looking at all of these things as nurses. So when we talk about nursing care and preventing infections, one of these has to do with our CART therapy 90% rule. And it's actually, World Health Organization 2020 goals is 90% rule, which means that we want 90% of those people diagnosed. We already said that early on, people don't realize that they have the disease, right? They just have flu-like symptoms. So we want 90% of the people diagnosed. We want 90% on treatment, and we want 90% virally suppressed, which means that virus is suppressed by the treatment. We have it under control, and the goal is that this will enable the world to end the AIDS epidemic. So remove that stigma of epidemic and bring it down to manageable disease. As far as our role in that, we're going to be checking CD4 counts and that viral load. Again, we're looking at those CD4 counts as indicators in higher levels as an indicator of immune health, and excess viral load, hopefully we're suppressing that. But if we're not, then of course that's autoimmune unhealth because it's affecting our CD4 cell counts. Frequent hand hygiene, my goodness. I mean, this just goes without saying, but here it is again. If you don't know this by now, always frequent hand hygiene, right? Being clean, being careful. Monitoring for fever, cough, oral lesions, UTI symptoms. So any of those things that would indicate to us that the patient is in the throes of an opportunistic infection and something that we need to help them with in order to help them not succumb to it and in order to not weaken the immune system further and overburden it. And then, of course, we're going to culture any wounds, urine, blood, and sputum, right? We're going to make sure that we're trying to stay on top of those infections and preventing sepsis. When we're talking about nursing care as it relates to nutrition, we're going to be monitoring electrolytes, right? We already said that there's malnutrition involved here, anorexia, cachexia, and we also talked about the significance of diarrhea affecting these patients. And we know that we can have, with excessive diarrhea, we're getting rid of that alkaline in the blood, and so we can become acidic. So we're monitoring electrolytes both because of malnutrition and because of excess diarrhea. We're going to assess for oral ulcers and pain, anything that would interfere with our patients being able to take in good quality food and adequate amounts of food. Medications for candidiasis, so we're going to stay ahead of that. Believe it or not, that can be very uncomfortable in the mouth, so we're going to treat that. And medications for diarrhea, we're going to try and manage that diarrhea, right? Help our patients to retain and not have those electrolyte imbalances, not having them suffer from the effects of the diarrhea on their appetite. We're going to monitor weight and intake and output. That's part of nutrition. We're going to encourage them to have an increased protein and calorie diet, so getting the most out of the food that they are able to put in their mouth. And then we might have some medications that you may or may not have heard of before. If you work in the healthcare field, you'd have heard of these before. We also use these with our cancer patients, so you will see them with those patients who are having trouble with appetite. But we're looking at megestrol or dronabinol, and we'll talk about those a little bit later in the next slides. So megestrol, we don't know how it works, but we do know that it stimulates the appetite. Obviously, it's a medication that's working on the GI symptoms, so we might see nausea, gas, and diarrhea. Hopefully not, because we're trying to help our patient with some of those problems that are interfering with their appetite. You may see increased blood pressure, impotence, or sexual dysregulation. Things that we might be concerned about: severe chest pain, sudden coughing or wheezing that might indicate anaphylaxis, hemoptysis, ketoacidosis. And again, we're feeding these to patients who already have metabolic issues with their diarrhea, right, potentially. So we have to watch these patients very carefully. Dronabinol, this is a THC, a marijuana derivative. So common feelings, they might feel high, they might feel dizzy or drowsy, they might have unusual thoughts or fears, euphoria. They can potentially have some GI side effects: nausea, vomiting, abdominal pain. As far as severe, we might see seizures, changes in heart rate, again, lightheaded or dizziness, depending on their age. That could be a real concern for falls. You may see neuro/mood changes, so sleep disturbance, memory, concentration, or loss. It makes sense when we're talking about the fact that we're doing a THC derivative that we might experience some of these side effects. Nursing care, we may be concerned about dehydration with this diarrhea. It's one of the concerns that we have with diarrhea. So we're going to document the frequency and the volume. We're going to get very specific about how often they're going, how much they're going, how much they're taking in. We're going to take anti-diarrhea medication on a regular schedule. So we're going to get these patients started on anti-diarrheal medications, knowing that this is going to be an ongoing problem. We're going to avoid dairy products, which can cause us to be mucousy and can irritate the digestive tract in some people. We're going to make sure that we have adequate fluid intake. Again, with diarrhea, we're losing a lot of fluid. We have concerns for dehydration. We're going to encourage them to do small, frequent meals, okay, not overloading the stomach. We're going to teach them about perianal skin care. Again, with that much diarrhea, we do have concern for cleanliness. We alluded to the fact that there were concerns for skin integrity. So we're going to assess for breakdown or infection, again, considering that malnutrition, diarrhea, inactivity, all of these things can contribute to skin breakdown. And then, of course, infection as well, opportunistic infections, and can include cellulitis. We're going to turn Q2 hours. Now, again, when we're talking about this, we're talking about our AIDS patients who are severely down that road of progression. So we're going to turn Q2 hours, and we're going to be very careful about how we do it. We're going to use pressure relieving devices. So there are foam dressings that we can use for areas that are at risk. We can use inflated beds that rotate pressure. So we're going to be using some of those things for our patients. These hydrocolloid dressings, which are healing. When we're talking about gas exchange, again, here we go. Here's the pronunciation. I was close. Pneumocystitis gyrovitsi, pneumonia. Okay, the most common opportunistic infection with AIDS and a common cause of death. We're going to assess breath sounds. We're going to assess respiratory rate, rhythm, pattern, cough, sputum, pulse ox, looking for signs of cyanosis. All of those things that we have learned about consistently throughout your program that are associated with respiratory distress and respiratory failure and respiratory concerns, right? No surprises as far as what we're assessing. We're going to use antibiotics for fighting the infection, and of course potentially bronchodilators, which may ease that work of breathing. We're going to teach the patients, like we always do with respiratory concerns, about coughing and deep breathing, getting those airways clear, and of course we're going to help them by keeping them in a semi-Fowler's position, which is going to enable them to breathe better. And if they need it, supplemental oxygen.